you. This is Amy Bilal from Maine Quality Counts. I'm one of the medical directors, and I'm going to turn it over to Kayla Cole.
Welcome, everyone, and thank you for joining. Today's webinar is part of our collaborative ADHD Learning in Maine project. And this project was started to really help support clinicians in Maine and also the families of children and children themselves in improving care for children with ADHD. And so this project it works with several practices throughout Maine, and we have a focus on making sure that we have improved diagnoses for ADHD, as well as educational materials for parents, and really talking with parents, communicating about what ADHD is, as well as working with our clinicians in Maine to help them troubleshoot some of the common issues they have with different medication managements and comorbidities. So thank you, everyone, for joining. And so just a few important webinar notes before we go ahead and get started. Right now you are in listen-only mode. We ask that you please use the Q&A function to ask questions or make comments. Today's speaker is Dr. Carol Hubbard, and she will be covering some different information on comorbidities and some medication management pieces as well. And she has said if you have specific questions around certain medications or prescriptions and interactions or just for treatment, feel free to put those in the Q&A box as well, and she can address those towards the end of the webinar. Your video screen size and location is adjustable. There'll be some little icons towards the top of where your video is displaying, and you can adjust those. Tomorrow you'll receive an email with links to the slides and recordings, and it will be archived on our Quality Counts website as well. We do have a new website. So if you haven't had a chance to go check that out yet, go to mainequalitycounts.org to view our new website. And Quality Counts is part of the Maine Child Health Improvement Partnership, and the mission is to optimize the health of Maine children by initiating and supporting measurement-based efforts to enhance child health care by fostering public and private partnerships, as well as the vision of all practices providing health care to children will have the skills, support, and opportunities for collaborative learning needed to deliver high-quality health care. So for today's CME disclosure, the speakers have no conflicts of interest with commercial products in this presentation. However, we do feel it's important to tell you that funding for the COM project is provided by the Pfizer Independent Grants for Learning and Change Group, which provides independent grant support to organizations for healthcare, quality improvement, and learning and change initiatives. The Pfizer Foundation is independent from the commercial entity Pfizer. However, funding for physician staff time is required to be reported under Sunshine Act reporting, and QC receives funding for staff time and subcontractors under this grant. For CME information, we will be sending out some CME follow-up after this. It will be available for participants who have signed into the webinar. If you have multiple people at one computer, we ask that you put their names and emails into the chat box, and this helps for our attendance records. We do not have separate nursing CEUs, but you can get a CME certificate and then use that to apply for your own additional CEUs. And a CME evaluation survey will be available when you exit the webinar. It'll be sent out via email. Please complete the survey via SurveyMonkey within a week, and a CME certificate will be emailed within 1 month of completion of the survey. And so now a little bit about today's presenter. We do have Dr. Carol Hubbard. We thank her for joining us. She is an expert in the field of developmental behavioral pediatrics. Dr. Hubbard received her combined MD, MPH, and PhD from the University of North Carolina School of Medicine, did residency training at Massachusetts General Hospital in internal medicine and pediatrics, and fellowship at Boston Medical Center in behavioral and developmental pediatrics. Dr. Hubbard has directed Maine Medical Partners Developmental Behavioral Pediatrics program since its inception in 2000. And she's also been helping us quite a bit with this collaborative ADHD learning project in Maine. She's attended our webinars and also was at our first learning session, and has been a great resource for us as we work with other clinicians to improve care for children with ADHD. And now I will turn it over to Carol.
Good morning, everybody. It's great to talk with you guys today, and I'm delighted to speak with you about perhaps some of the more complicated aspects of ADHD. We have several different topics that we're going to cover today, sometimes managing a child with ADHD can seem a bit like a jungle, as this beautiful photo of the cloud forest in Monteverde, Costa Rica reminds us. So hopefully today we will wade through some of the underbrush and maybe clear away some of the vines, or the lianas in this case, and help you to see the forest for the trees, or maybe the trees for the forest. So our agenda today is to look at the comorbidities, consider ADHD in teenagers, which was a special request, I think, of the group, and then, time allowing, a little bit of medication tips and tricks. No disclosures, as mentioned. So first we're going to talk about comorbidities, and this slide is a forest closer to home, Pleasant River in Maine, and it reminds me just to mention that there's so many different aspects of life that can make things complicated for children with ADHD. Just like in this landscape, there's different aspects. And so on the next slide, we'll see a list of some of these things. I'm going to show you several different slides that look at comorbidities in different ways. And I think it's tricky to think about whether it's a comorbidity or whether some of these things could actually be differential diagnoses for ADHD. So it can be sort of a chicken and egg situation. This slide is provided by the American Academy of Pediatrics National ADHD Project and divides issues into medical, psychological, and educational comorbidities. So in medical issues, sleep disorders are paramount, and it's really helpful to look at sleep for children with ADHD really at every visit, because sleep can mimic or confound symptoms of ADHD, or sleep deprivation can, and also many of the medications that we use can cause sleep difficulties. Tourette's syndrome or tic disorders in many cases can present with symptoms of ADHD before tics are even present, so maybe in about 30% of cases. And also tricky when stimulant medication is started, because then it's sometimes hard to tell if tics are due to the medication or an underlying tic disorder. And then traumatic brain injuries can mimic symptoms of ADHD, especially if there's frontal lobe damage, and there's some famous cases of this. But children with ADHD are also at higher risk for injuries, including brain injuries. Looking at psychological issues, you see the list here: internalizing disorders like anxiety and depression. OCD is an interesting case because you might think that the symptoms of OCD and ADHD in some ways could be opposite, but they can both contribute to a child or a youth having a slower processing time and difficulty getting through tasks for different reasons. We'll talk more about ASDs, or autism spectrum disorders, and then some of the issues that occur in older kids: substance use, PTSD, and then we'll talk more about ODD and conduct disorder. Looking at educational issues, learning disabilities or dyslexia are very common. And for children with ADHD, when cognitive testing is done, often they have a cognitive profile that may show weaknesses in processing issues or in working memory. And nowadays, learning disabilities are defined as processing disorders, so this is an issue to be aware of. And for some children, their cognitive deficits may even rise to the level of intellectual disability. So children with intellectual disabilities can be diagnosed with ADHD. We just have to think about whether the ADHD symptoms are out of proportion to the child's developmental age. This slide shows some of the rates of different comorbidities. So ADHD is a very comorbid disorder, and the overall rate of comorbidity is felt to be above 60%. And you can see the estimates for different conditions on this slide, and you note that they vary widely, and these are based on different published studies. I want to make a special note of oppositional defiant disorder and conduct disorder, and this is my editorial comment. I really advise caution in diagnosing ODD in kids that have ADHD, or any child, due to the pejorative nature of the label. And I don't really know how helpful it is as a label in helping a family to rally around a child and support them and work together to overcome the challenges. And keep in mind that ADHD can explain a lot of oppositional symptoms, and for many children, not all, but many, treating the ADHD can actually help with resolution of some of the behavioral challenges. Similarly, conduct disorder I think is a term that can be overused, and we often get children referred to us for, quote, childhood conduct disorder, but conduct disorder indicates really significant behavioral issues. It's a DSM diagnosis that involves things like fire setting and truancy and harming animals and such issues. So I feel that it should really be diagnosed by a mental health professional. And then there's some other comorbidities that are interesting and maybe more recently recognized. Many children with ADHD have motor problems, and I think in some cases this can be due to inattention or impulsivity themselves, but bona fide motor disorders are common. And interestingly, eating disorders as well. So the odds ratio is about 2.6 for any eating disorder, and even more increased at 5.8 for binge eating, which I think speaks to the impulsive nature of habits of folks with ADHD. Folks with ADHD are also at increased risk for obesity. Estimates vary, but it can double their risk for obesity. And I do worry about children who are underweight, perhaps due to medication for ADHD when they're young, and we work really hard to get them to eat more calories. And I think we also need to consider the patterns of eating that this may set up for the long run. And then I mentioned the issue of comorbid autism spectrum disorders, and there's quite an overlap. So 20% of children with ADHD are felt to have autism spectrum disorders, and it's recognized now that up to 70% of children with ASDs can have comorbid ADHD symptoms. We often get children referred to our practice for questions of autism, and sometimes we end up thinking that they're so impulsive and inattentive that we need to treat their ADHD first and then see how their social pragmatic function is after that. This slide shows some other comorbidities, or you might call them risks or sequelae of ADHD. Nocturnal enuresis and toileting issues can be quite common in ADHD, and we find in our Potty University clinic that treating ADHD can sometimes really help children progress if they have delayed toilet training. And it's really interesting, sometimes when medication wears off in the afternoon, a child will start to have more accidents, I think maybe because they're just not paying attention to body cues as much. We've talked about sleep problems, injuries. Child abuse is a risk for kids with ADHD, I think, because they're challenging to live with and their parents may themselves also have ADHD or impulsivity. Peer rejection and bullying, school suspensions and expulsions, academic challenges. So the data is that a child with ADHD is 3 times more likely to repeat a grade, 15 times more likely to receive special education, which I think can also be for some of those comorbidities, and less likely to graduate from high school. And I think all of these things together can contribute to the loss of self-esteem and motivation and learned helplessness that can be some of the worst long-term sequelae of ADHD. Next slide, please. So the best thing to do is cast a broad net in your screening when you're assessing kids for ADHD. The Vanderbilt and the Connors questionnaires both have questions about anxiety and depression. Other instruments that are in the public domain are the SCARED and the PHQ, which I think is being more widely used now. In our clinic, we also use the BASC, which is a questionnaire that has to be purchased and scored, but it does include questions about a wide variety of internalizing and externalizing symptoms. Next slide, please. This is also our teacher questionnaire, which I mentioned in our first workshop this year. We really like this. It's quick, it's 2 pages. It has all the ADHD symptoms, so you get that information so you can use it as a diagnostic tool, but it also gives the teacher a way to give you some narrative information, including about comorbid issues like anxiety and also, well, and social skills, and also a child's strengths, which is really nice to have. For these complicated children where there are comorbidities, consider involving other professionals to help assess and support the child. So just in general, developmental behavioral pediatrics or psychiatry can be useful. And we, in our practice, take referrals of children with complicated ADHD where there's comorbid issues or medication has been tried, but there's still challenges. For suspected cognitive or learning delays, the school IEP team and assessment process really is paramount, or consider private psychological assessment, being mindful of insurance issues. For depression or anxiety, a therapist or a psychologist. For sensory issues, occupational therapists can be very helpful. And while I am skeptical about the ability of sensory or occupational therapy intervention to actually change a child's brain or reprogram it, as is sometimes claimed. These kinds of interventions can be incredibly helpful to manage daily life for kids with ADHD as ways to get out energy or hand fidgets or all sorts of different creative interventions. And OTs can also help sometimes with planning and organizing and strategies like that. For communication issues, speech and language pathologists. And the AAP guidelines for ADHD suggest ongoing bidirectional communication with school and mental health clinicians. I think a common question is, what do you do about a child who has ADHD symptoms, but also you wonder about learning difficulties? So we suggest treating for ADHD if the child really meets the diagnostic criterion in more than one setting, as is required for a good diagnosis. Advocate also for assessment of learning through school, and then consider whether there may be risk factors for a learning disorder, such as an early speech and language delay or a family history of learning issues. And then looking at medication management of ADHD with comorbidities, I've given some ideas on this slide. For ADHD plus anxiety, stimulants can be helpful, but they may also exacerbate anxiety and irritability. So we sometimes use guanfacine. Strattera is designed for this particular target population. This is the group of kids for which it's most likely to be helpful. Or a stimulant plus an SSRI is a really good combination. And that, as you can see from this slide, can also be helpful for ADHD with depression or irritability and also with OCD. And then Wellbutrin or bupropion we sometimes use for ADHD and mood issues, hoping to be able to affect both of those. I also want to put in a plug for physical activity as an intervention for ADHD and mood and sleep and anxiety and really in learning, actually. I would also like to encourage you all to attend Dr. John Rady is coming as a speaker for the COM and AAP conference in Freeport on April 13th and 14th. And he's a wonderful speaker who's done a lot of research on physical activity and various behavioral health issues. So this particular slide shows a study by Ng and others. And so in his review, or her review, they reviewed information that animal and human studies have shown benefits of physical activity for many different aspects of neurobiology, including neuroplasticity, cognitive function, focus processing, and mood. And there's a lot of different research studies that support this. There are interestingly few intervention studies for ADHD itself. So those that have been done have shown short-term benefits, including significant improvements in response time, accuracy, and processing, and decreased impulsivity right after brief periods of exercise. And then longer-term benefits of 8 to 12-week programs have included a reduction of severity of ADHD symptoms, especially response inhibition. And I think we're all familiar with anecdotal reports of the benefits of physical activity for various athletes. For instance, Michael Phelps is often quoted as someone who has ADHD, and I think perhaps did not take medication when he was younger. So I'm going to turn now to ADHD in adolescence. And that was a picture of the Spurwink Marsh, Spurwink River in Cape Elizabeth and Scarborough. So what is the data on persistence of ADHD into adolescence and adulthood? The prevalence is felt to decrease over the course of adolescence to about half that in children. However, the persistence into adulthood is also thought to be about 50%. So I think the data is a little variable here. And this may be partly because of methodologic issues in the study. So the range of persistence into adulthood has been quoted to be up 11% up to 76%, which is obviously a big range. And this can depend on how the symptoms and the level of impairment are defined and measured in the studies. And interestingly, there may be a higher persistence rate in girls and women. And predictors of persistence include the severity of ADHD at baseline, comorbid depression, and also comorbid conduct disorder can signal higher chance of persistence. A family history of ADHD in adults is also a risk for persistent ADHD. And then sort of interesting and sobering data is treatment for ADHD as a child can predict persistence. And there's debate about this. This is controversial, and it may be that those are the children that are more severe, so they're more likely to be treated. But I think that is an area where there's research ongoing. And now there's actually a number of large studies that have shown evidence of what's called late or adult onset ADHD, where a person really didn't seem to have symptoms as a child, but do show symptoms as an adult. And this somewhat flies in the face of what I think many of us have been taught about ADHD, but it's literature that's worth watching. Over time, the pattern of symptoms may change in an individual. So through adolescence, hyperactivity tends to improve or become more subtle, so maybe more of a sense of restlessness. Impulsivity can change form, so maybe less physical, and it turns more into risk-taking or low frustration tolerance. And these features can make a person seem kind of emotionally immature. Unfortunately, organizational difficulties are lifelong, or can be, and are said to be one of the more challenging aspects of ADHD for adults. And executive function deficits, including the frontal lobe functions of planning, prioritizing, maintaining and shifting focus, metacognition, and so forth, those deficits can take a toll in adult life and adolescence. Teens have their own set of sequelae and comorbidities. They're at increased risk for smoking, alcohol, and other substance use. Depression and mood disorders and anxiety, I think, become especially prominent because, in part, they are aware of their differences. They may show so-called antisocial behavior, but then at the same time, they're often shunned by peers. And they're at increased risk for suicide and motor vehicle accidents and other sorts of accidents. This slide has a somewhat daunting list of impacts for adolescents. And again, it brings us back to the jungle of the way life may be for these kids. So in terms of academics, in high school and middle school, workloads are increasingly complex. There's more teachers, there's more need for planning and independence on projects. And teachers can get frustrated by poor attention, follow through, and task completion. Kids with ADHD, as they get older, they're found to have lower GPAs and standardized test scores and increased rates of school failure and suspension as a population. Social challenges include challenges with peer relations, which are felt to happen in at least half or more of kids with ADHD, and they tend to have fewer friendships and can be socially isolated. Peers can view them as immature or loners or losers. Their inattention, intrusiveness, and quick anger can compromise relationships inside and outside the family. Their impulsivity, as we've discussed, can lead to risk-taking behaviors, and at home even there may be strained relations with parents. So the impact on self-esteem is significant. There can be a pervasive sense of failure. So kids that are bright but really struggle with these sorts of planning and work completion can feel like failures. A lack of affirmative connections because they're surrounded by people that are annoyed with them. Delayed independence, which can be really challenging for a teen who wants desperately to be independent. And then the risk of increased comorbidities like depression and conduct issues. And the good news to all this is that the prefrontal cortex continues to undergo maturation and pruning through adolescence and into early adulthood. So it really is the area of the brain that develops the longest. And this is well worth sharing with your patients with ADHD. For teens, there's this challenge of balancing independence with this need for support because their developmental task is to become more independent. One thing that I think can be done is to think about self-determination and how a person makes decisions for themselves, and to allow a child or youth opportunities for choice and decision-making as much as possible so that they practice these skills as they get older. Thinking about independence from parents, this is a helpful thing to try to nurture as much as is possible and feasible and safe. So the school team can really play an important role here, and they can take over some of the functions that the parents may have been providing earlier in terms of encouraging work completion and structuring the students' work habits and so forth. And I put an asterisk here because I found that teens may need advocacy from medical providers to the school to have this ongoing organizational support. I've seen many cases where students are penalized as they're in middle and high school, kids with ADHD, because they're not organized and they're not completing work, but that's really the crux of their disorder. So I feel strongly that that should continue to be provided by the schools, ideally with attempts to wean it and help the child to learn to become more independent. Tutors and homework helpers can be really helpful to take parents out of the picture, and I recommend websites like care.com, which is a place that one can find tutors, people with special ed background, sitters, nannies, and so forth. ADHD coaches are available who help with structuring and planning and organizing. Often are not covered by insurance unless they happen to also be a psychologist or a therapist. And those folks can also be very helpful for the self-esteem and other social interaction issues. It's recommended generally to think of a child or a youth with ADHD as being about 1 to 2 years younger than their chronologic age. And this can help with thinking about what they may be able to do in terms of independence and self-determination. CHADD is an organization, it stands for Children and Adults with ADD or ADHD, and it has websites that have a website with a lot of information, and there's a really good section on parenting teens with ADHD. In terms of communication with teens, I think it's really helpful to really listen and try to get the teens' input, and collaborative problem solving is a approach that can be very helpful. This is Ross Green's approach, and you can find it on his website, livesinthebalance.org, and he's also involved with this CALM project as well. It's advisable to keep communication brief and to the point. Consider the modality of communication, whether verbally or texting, whatever may be most helpful for that teen. Maintaining a neutral tone and keeping cool is a tricky thing for parents, but helpful. And giving positive feedback whenever possible, understanding how much subtle or not so subtle negativity a child with significant ADHD may experience, or a teen. This cartoon is Zetz from Zetz, and I think this shows why these things can be so challenging for kids. So the teenager says, "Mom, we have to talk. I didn't want you to take this the wrong way, but your weird little mannerisms are driving me crazy. I've tried to be patient and hold my tongue, but I'm this close to snapping." The mom says, "All I did was walk into the room." And the teen says, "I rest my case." I think that applies to many people parenting teenagers, maybe even without ADHD. So this slide lists some organizational support ideas for teens, and these are ideas that we use in our practice and some things that have been gleaned from the various websites that are available. So again, it's helpful to encourage a teen to engage in increasing independence. So finding developmentally appropriate chores or tasks. So parents should not just continue to put away their child's dishes or do everything for them. And this can be challenging because it may take longer to help the child do it themselves than for the parents to do it. Dividing and conquering, offering support to the child or teen, supporting the development of organizational habits. So providing the physical mechanisms for them to do this more easily, such as open storage so they can see things, hooks, zones of organization, labeling storage, purging their wardrobe, putting a recycling bin in their room, and then having a launching pad or a particular place where they can keep their stuff, and then organize it. And these are the sorts of things that a ADHD coach might also help with. Encouraging list making and calendar use, encouraging putting away electronics to avoid temptation, especially in the evening, motivating with music to set a positive tone, thinking about ways to positively impact the morning routine. And I think it's especially helpful to advise people to use 2 alarms, not just 1. So a first alarm means it's time to get ready. And then the second one is it's time to actually do the action, like it's actually time to get to bed or it's time to get out the door, so that there's a little bit of advance notice. Some of you may be familiar with life hacks, which is a concept that you find now online on YouTube. There's lots of websites that talk about life hacks, which are clever little ways to do things, everything from peeling a hard-boiled egg, which you can do by putting in water and in a container and shaking it, to dealing with your ADHD. So I love this site, and it has 41 hacks to help people with ADHD work and feel better. So I list only the first 10, and on the website they have text under each one of these that explain them in more detail. And I think this could really be appealing to teenagers who are probably familiar with the life hack concept, so I'm printing it and giving it to folks in clinic. And then I have my own hacks, which are include physical activity and get adequate sleep. So looking at more formal intervention, so psychotherapy. Treatment for ADHD, as you've learned in previous presentations this year, really consists most effectively of behavioral parent training and also teacher training. And not surprisingly, the impact of this approach, this most effective approach, is more modest for older kids than it is for the younger children because the parents are less involved. So there are other evidence-based approaches, specifically CBT and DBT. CBT can be beneficial for some teens with ADHD. It works on self-awareness, cognitive restructuring, so trying to get around their negative thinking and reframe things in a positive way or help them with reality checks, adaptive thinking, planning, and organization. And DBT was developed initially for folks with bipolar disorder and borderline personality disorder, and targets emotional dysregulation and interpersonal difficulties. So using techniques like mindfulness, distress tolerance, emotional regulation, and working on interpersonal effectiveness. Interestingly, the AAP guidelines for ADHD rate evidence for behavioral interventions for teens as only category C. So really medication is potentially as or more effective piece of intervention. And there are some challenges with medication for teens. One of them is adherence. So earlier this year, Dr. Balker-Kinley talked about personality suppression, which is, I think, an apt term for a common complaint in teenagers. When they're on stimulants, they feel more subdued, less funny, less spontaneous, less conversant. They say their friends really like them better off medication, so this may be a reason that they stop taking medication, in particular stimulants or guanfacine. Teens may also express philosophical objections to taking medication. They don't want to do it. They want to do it themselves, and so forth. So some strategies are to consider holding stimulant medication for weekends or on weekends or holidays, and if possible, or if it's not as critical, or using a short-acting form for specific intervals during the weekend. Considering trials of lower doses, or a trial off medication with data collection and involving the teen. So this is sometimes really effective if you do follow-up questionnaires for a week on meds and off meds from the teachers, and then you review it with the family and you can see whether or not it made an impact. And then considering a non-stimulant medication. There's also the issue of misuse or diversion, which can become more prominent for older folks. Stimulants are misused to augment scholastic performance, for work productivity, to combat sleep deprivation, for instance, in the military. They're apparently used this way. And they're known to improve cognitive performance in people with and without ADHD. So there's a demand for these medications. And some strategies to consider for this issue is ongoing parental monitoring of medication. It's amazing how many people let their children take their medication independently, and I think just the parents being involved and at least aware of the supply of medication is helpful. Discussing peer pressure and that other people may ask for the medication, and emphasizing the legal ramifications of selling or sharing medication, which is illegal. The importance of keeping medications secured, for instance, for a college student. In some cases, using a medication contract or treatment agreement, or switching to a non-stimulant medication. Another significant issue is driving with ADHD. So drivers who have ADHD are well known to be more likely to have traffic violations, including all sorts of different things: driving without their license, having their license revoked, having multiple car accidents, and speeding citations. And I have patients who have very much followed this pattern. And factors for folks with ADHD and others include speed, inexperience, inattention, and fatigue, as well as the distractibility and impulsivity that are intrinsic to the disorder. Medical treatment, interestingly, has been associated with faster reaction time and lower likelihood of accidents, even independent of a documented clinical response for ADHD symptoms itself. So it does seem like this is a role that medication may be able to play. So in terms of intervention for driving, I definitely recommend considering waiting to take driver's ed and to get a permit if possible, if appropriate. And again, that falls into the rubric of thinking of folks with ADHD as a year or two younger developmentally. Consider when medications are active in relation to driving time. So stimulants may be very effective, but they likely wear off by the evening. So you could consider a short-acting booster dose for evening driving, but then you have to monitor sleep because they could impact sleep, and that is not good for driving in itself. Or try to avoid driving in the evenings, which can be challenging. Consider a non-stimulant medication like guanfacine, which can last more throughout the day and evening, but then in itself can cause tiredness. And then for folks where you have real concerns and you think their impairment is significant, there are specialized services like Alpha One that can do adaptive driving assessments. And these are really for people that tend to have more significant issues. So I think I will keep going unless I hear indication that we need to switch gears. So we'll talk about a little bit about medication now. And I tried to think of issues that might be of interest to CALM participants, knowing that you guys have had quite a bit of experience in general and over the course of this year with ADHD treatment. I think one question that may come up is what medication to start with. So in general, the data supports stimulants working better than other medication classes. And they can also be titrated quite quickly. So they're often the first choice of medication for ADHD. There may be specific times that you might want to start with a non-stimulant, and this could be when symptoms are most problematic at home or in the evenings. So a stimulant is less likely to be helpful then. In fact, might make those issues worse because of rebound. So guanfacine could be an option. If a child is really underweight or growth is a concern or appetite, if there are congenital cardiac or other cardiac issues, and stimulants need to be used in caution in these situations, so I strongly suggest consulting cardiology. If a child has significant comorbid anxiety that is really prominent, you might consider Strattera or guanfacine. Or if there's concern about diversion or misuse of stimulants by the child or someone in the family. And then glaucoma is actually a contraindication to stimulant use. It's reassuring to know that no stimulant class has been shown superior to others. So in meta-analyses, there's a pretty equal response to the amphetamines and to methylphenidate. So it doesn't really matter which group you start with. It is helpful to think about where and when the symptoms are most problematic, especially in terms of time frame across the day, and to really target that time frame. And so most children do not tolerate stimulants late in the day due to insomnia and appetite suppression, but there are some children who actually seem to sleep better with stimulants. I think those are the ones that are so hyperactive that they can't calm at bedtime. It's one of the main things about stimulant management is being aware of rebound symptoms. So irritability, an exacerbation of ADHD symptoms that happens as the medication wears off, and generally lasts maybe an hour or so. And those are times that it's very, very important to warn families about that in advance, because they'll think things have gotten worse. And this happens not in all children, but in many. And it may be a time that the child should just do something calm, not interact with other people. Or you can try some strategies like adding a tiny dose of a short-acting stimulant or adding guanfacine to try to manage that. You don't have to take stimulants every day, so they don't have to be taken on weekends or holidays, or if there's a divorce situation and one parent wants to use them and the other doesn't. It's not optimal, but it's possible to give them on some days and not all. And I do think a trial off of them periodically to see if they're still needed is helpful. And then it's really important to continue to gather data. So if you look at the next slide, this is a form that we really enjoy using in our clinic because it divides the day into morning and afternoon. It's called the CAPS, or Clinical Attention Problem Scale. And so you can really see the time course and whether the medication is lasting all through the school day. And it also gives a little spot for narrative comments, which we pay a lot of attention to, so the teacher can jot down their thoughts. You're probably familiar with stimulant side effects. This is a list of them, and I highlighted a few of them. It's worth knowing that suboptimal stimulant doses can occasionally result in increased hyperactivity or irritability. So you might try a moderate dose on a Saturday, and if things don't go well, advise the family to do a higher dose on Sunday and see if it's better. The stimulants have long been thought to exacerbate tics, but recent studies have actually suggested that, in fact, they may not. We often see skin picking as a side effect, so kids that are picking at scabs, and that can be tricky. And priapism is a newer recognized side effect of stimulants, so it's important to tell people about that. And then the growth issue is, especially during the first few years of treatment, there's more data recently that stimulants really may, in fact, impact growth. So the long-term effects include the growth issue, and some of the more recent studies, the multimodal treatment study and others, have suggested possible impact on adult height. So I think this needs to be balanced with stimulant efficacy. And then on the other hand, there's some positive impacts of long-term impacts. So several studies have shown protective effects against the development of internalizing disorders and disruptive behavior, and also grade retention. And I think a common question that we get is whether, if we give a child a stimulant, is that opening the door to other drug use? And in fact, if anything, it seems like it's the opposite, that they seem to tend to decrease that impulsive, risk-taking drug use kind of behavior. I've mentioned the growth suppression, and this lists some of the strategies that we use really to try to increase caloric intake, especially realizing the child may not eat lunch. So they may need to eat a lot of their calories before the medication is in their system and at bedtime or later on in the day when it wears off. And then we will somewhat reluctantly use cyproheptadine if needed, if other measures aren't helpful for sustaining adequate weight gain. And then considering times off the medication if possible, or switching to a non-stimulant. I mentioned cardiac risk. So there was a panel back in 2006. There were a couple panels that looked at this issue because it was a bit controversial at that time. But ultimately, there was not found to be an increased risk of sudden death for stimulant use in healthy patients. And there have been large follow-up studies that have supported this. For a child with a pre-existing structural cardiac abnormality, it is useful to treat them with caution and realize that there can be some risk, but it's lower than that posed by strenuous exercise. And again, involving cardiology is really helpful. And we are careful to take a personal and family cardiac history before we start stimulant medication. So ask about arrhythmias, palpitations, dyspnea with exertion, syncope, which is not that uncommon if someone's out of shape, syncope, or anyone in the family who had early sudden death or early pacemaker or defibrillator use. And then I think I'll finish by talking about the alpha agonists. This is a useful class of medication. So they work by a different mechanism. The stimulants work by dopamine, on the dopamine system, and the alpha agonists stimulate alpha-2 adrenergic receptors, and so they work in the prefrontal cortex to enhance effectiveness of pyramidal neurons, which has been shown to improve working memory and attention. And they actually cause structural changes in these neurons, like promoting growth and maturation of dendritic spines, which might be one reason that it can take a few weeks for these medications to really take full effect. And you can see the side effects listed there. I think the headache and the sedation in particular are things that we see that I warn folks about. And the sedation can get better with guanfacine. It's not really a useful medication for sleep. Clonidine I'm very careful to use during the day, and I mostly, it's quite helpful for sleep, but it's mostly used for sleep. So these meds can be used as a second-line agent for a child who doesn't tolerate stimulants, or an alternative for a stimulant-refusing teenager. Augmentation for those afternoon or evenings. They can be helpful for impulsivity and emotional reactivity. They can be used if you're worried about diversion. Also, if there's a tic disorder, they're a really good medication to try adding. And then, as I mentioned, Clonidine is quite useful for sleep. Guanfacine takes 2 or 3 doses per day. Usually 2 doses a day is helpful. And it can be helpful to start after school in case the child is quite tired on it, and then increase gradually. And it comes as, the smallest dose is 1 milligram. So starting with half of a tablet is often a good practice, and it can be crushed. The longer lasting form, guanfacine ER or Intuniv, now there are generics available, is once a day, in rare cases twice a day, and generally, and the lowest dose is 1 milligram. One of the things that I've found with Intuniv is it does seem to be linked to significant weight gain in some cases, and that's starting to be reported in the literature, so I'd be cautious about monitoring weight. And then even though sedation is a very common side effect of guanfacine, insomnia can also occur, so we have to watch that. And then I think I'll finish with Strattera. So this is a selective norepinephrine reuptake inhibitor, and is really used for kids especially that are anxious and also have ADHD. It has to be swallowed whole, and it can cause significant irritability, so I think that can be a somewhat tricky issue, but can be helpful. And I think I'll finish there.
Great. Thank you very much, Carol. You have a few questions on medications if we want to go to those questions. The first question is, do you typically start with a short or long-acting stimulant?
That's a great question. I think it really depends on the patient. So for younger children where it's known that there can be a higher rate of side effects, like from the results of the PAD study, I do tend to start with a short-acting, also because those children may be going to sleep earlier in the evening, so I don't want to impact sleep. So I would tend to use short-acting in that case, or if people have concerns about the medication or reluctant, I just might want to see what would happen for a shorter period of time. For older kids, I'm more likely to start with longer acting, or for folks that don't want a child to have to take medication during the school day. A short-acting form can be helpful for a child who really doesn't eat lunch, because sometimes you can dose a short-acting form in the morning and then again after lunch, and there may be enough wear off during lunch so that they may have a little more appetite.
Great. Another question is, how young would you consider a stimulant with SSRI for comorbid anxiety?
Yeah, that's a great question. You know, I think that depends a lot on the severity of the symptoms. I would say for sure a 4-year-old, I would be comfortable with that. Younger than that, we have on rare occasions treated 3-year-olds, but I think with great caution. And again, it depends on the severity of the symptoms. I think child and adolescent psychiatrists I've seen use medications in younger children, but they tend to also be dealing with children with more significant mood and anxiety issues. But I would say 4 or 5 for sure.
Great. Another question, can you talk a little bit about children with intellectual developmental disabilities or delays and ADHD, and what your approach is to treatment?
So I think for those children, it's really important to be advocating for services and supports, especially to make sure that they're at a reasonable educational program in school, that they're at the right learning level, and that they're being supported in that way. And then to consider how impairing the ADHD symptoms are. And I do think for those kids, if they have prominent ADHD symptoms, we often try treating them, just hoping that maybe if they can focus better, their pace of learning will be faster. And I do think that that's the case in some situations. So I'm just trying to think whether it's that different than a regular child with ADHD. I think it can seem complicated because you wonder, is it just the intellectual disability? But if the child fits criterion for ADHD, even appropriate to their developmental level, so say it's a 10-year-old, but you feel like maybe they're functioning at a lower level, but they're still hyperactive and impulsive compared to what you would expect, I would definitely err on the side of treating them. There's not a lot of downside to it. I mean, you also want to be sure that you're doing a good workup for their intellectual disability, that if needed, they have genetic assessment, and that they have good cognitive testing in place to look at their cognitive profile. I think sometimes there's other underlying issues like fetal alcohol syndrome can result in cognitive impairment, and also ADHD, and can make it a lot harder to treat the ADHD. But that population is really a lot of the kids that we see in our clinic.
And I know you focused a lot on the teens and the life hacks for them. How do you start to counsel them as they go off to college? What are sort of your biggest words of advice as they transition from home to maybe another setting where they're living?
So I think one issue is medication management, and are they independent in taking it? So you want them to have had some practice before they go, and are they aware of the controlled substance nature of their medications, and if they are, and keeping them locked up. That's probably one of the bigger things that I suggest, not sharing them, being cautious about substance use, especially together with their medication, letting them know that their ADHD may put them at increased risk for, substance use and trying things. So just to be really cautious, and then especially counseling them to try to get regular sleep and to continue to try to get physical activity. And then every college is supposed to have a student support center where folks can go and get help. And so it's different than in high school, because special education services in college are not mandated. So a person has to seek them out themselves. So I strongly suggest to students that they get plugged in from the beginning with the student support center. If nothing else, just to set up structure for themselves if they need to go for weekly tutoring or meet with their advisor regularly and that sort of thing. And then I also often will suggest actually that people might consider whether they really want to take a full course load or not. Because I've had experience with a number of patients who have gone to college and have really failed spectacularly because they, I think, took on too much. And if they had taken a couple of courses at a time, or started at a local community college, lived at home, and just gotten their feet wet, I think that can be a more realistic approach and give them better success in the long run, perhaps.
Great. And another question is, who do you suggest needs to be referred to you or to a specialist, someone that should not be managed in primary care that may have comorbid conditions? Who are you seeing, and who should they be sending to you?
To us, yeah. So I think this is sort of a painful issue because we would like to see everybody, but we are limited really by our waiting list. It's not so much by who we can or want to see. So we, our practice in developmental pediatrics has a special focus on autism for that reason, because that is a condition where perhaps there's less resources otherwise or elsewhere. I think for children that have ADHD and significant comorbid mood disorders or anxiety, they should be referred to psychiatry, because psychiatrists will manage them well, and probably as well or better than us. For significant developmental delays, like intellectual disability or autism, and ADHD symptoms, those are a good population to refer to us.
Great.
And I would also say, Amy, that I would really encourage people to use the school resources, because sometimes we'll get kids referred to us and we don't necessarily know exactly what the reasons are. And if a child has had extensive evaluation through school, we are going to try to ask for that and try to get that before we set them up for a big psychological evaluation through our practice, because some of the issues may have already been addressed. And it may be a question of communicating the results to the family or making sure that the school is following through on the results. So I would definitely encourage getting records from school, and if possible, trying to get those on to us if you do refer a patient, because we spend a really lot of time trying to get those records to make sure that that our full evaluation is needed, because a psychological or neuropsych eval can be an 8-hour process, and it's tricky to embark on that if a child has had testing within a year, unless there's questions about the validity of the other assessment, which does come up.
Great. Thank you very much, Carol, for spending the noon hour with us and for all the preparation that you've done for today.
Thanks.
Kayla's going to wrap up and just show the folks who are in our COM collaborative their data and wrap up the webinar. I will note that Carol did several presentations at our last learning session back in October, and we've had several webinars. For those of you who are just joining us today, we'll have those posted on our website in case you want to go back to look at those. So I'm going to turn it back over to Kayla, but thank you very much, Carol, for all the work you've done today and throughout the year with us. We really appreciate it.
Yes, thank you. And for those practices participating in the COM data collection, I just wanted to touch base really quickly. We know that there is some data missing, but we also know that it's flu season right now. And on top of flu season, there's also this horrific cold that's going around. And I'm actually speaking for Sue because she personally has that cold. So we know you're busy, and some of your patients that you would usually see for their ADHD care, maybe, those appointments aren't happening. But just as you have data available, please submit that. And so we just wanted to review a few data points with you. If you have any questions, you can certainly reach out to me and let me know. And we'll include these in the handouts that we send to you. But you can see that there's definitely an upward trend for percent assessed using DSM-5. Percent of visits in which the patient's weight, blood pressure, and pulse were documented is on the rise as well. We have an upward trend for percent of patients initially diagnosed based on data valid from a validated ADHD parent and teacher rating scale. Percent of visits in which data from a validated ADHD parent rating scale was used to monitor response to management has gone down a bit. And we know that some of these numbers are changing throughout the course of this project as different practices are focusing on different measures. We're fully aware to track and focus on all of these measures would be a little bit difficult to do. So we, in the beginning, did ask you to pick a few things to really focus on. And I'm not going to go ahead and read through every data point. As I said, we'll send these out to you, but we just wanted to show you some of the aggregate data trends so far to date, and that we'll just keep watching. And if you need any additional support on your data or have questions, certainly reach out to me. Also, Sue is available for quality improvement coaching if you would like a session with her. And then just a few reminders. We do have an upcoming webinar on March 8th, and that's Collaborative and Proactive Solutions for Children with Challenging Behavior, Lives in the Balance with Dr. Ross Green. And then also for the COM members, please make sure you register for the Friday session on April 13th, which is our final COM learning session. For all of those attending the call that aren't necessarily part of the COM group, the Maine AAP conference is that weekend. It's April 14th. So you can feel free to go to their website to learn more about registration in the program. As Carol did mention, Dr. Rady will be speaking, and that will be a fantastic session. There's a lot of great sessions as well. Again, we do have a new website for those of you in the COM group. I did send out instructions on how to navigate to there. It's the same, mainqualityaccounts.org, and you can select initiatives and resources in child's health. COM, Collaborative ADHD Learning in Maine, has its own tab you can select. And this bubble is a little off, but there is a space right here where you can select to get to QI Teamspace to enter your data. If you have any issues with finding where QI Teamspace is, just go ahead and email me and I'll help you with that. And just a reminder about requirements for physicians desiring the MOC credit. The requirements are to attend the 4 webinars, the learning sessions, help set goals, be involved with the goal setting and the aims, and really the monthly PDSA cycles as well. And then our contact information, again, if you have any questions on any of the information we went over today, feel free to email us. And I just want to say thank you to Carol again for your wonderful suggestion. I know that's a lot of people have different questions around these topics, so it was great that you were able to spend the time with us today. And thank you for everyone who attended.